I've seen so much just as the person caring from the other side, that babies that quite honestly, they pulled off life support, right? They pulled it because they thought, all right, there's too much wrong. Who then survived and thrived. And I mean, it's amazing. So the good thing, yes, I definitely want to reiterate for parents, if you're in the room and the ophthalmologist says, okay, I'm worried there is some retinopathy, prematurity, that is not cause for alarm. Your head doesn't have to, because mine would go there with my three kids. Okay, now we got to do surgery. Now we got to do this. Now we got to do that.
This is NICU Babies Parent Support with Kathryn Whitaker, a podcast from Hand to Hold, a national nonprofit that provides free personalized support, resources, and community before, during, and after a NICU stay. My conversations here focus on education and personal stories with medical and hospital professionals, counselors, therapists, and NICU moms and dads from across the country. So whether you're preparing for a NICU stay, you're currently there, or you're months and years past your stay, you belong here. The NICU is hard. We're here to help. I'm your host, Kathryn Whitaker, the mom of 6 children, including my very own NICU baby, and I'm so grateful that you're here. Howdy, y'all, and welcome back to the podcast. Okay, I'm going to start today's podcast with a confession. There have been multiple times that our preemie has received a new diagnosis or a new specialist, and instead of asking said specialist, or maybe even another parent who's experienced the same thing, I will admit that I have gone to Dr. Google and I have spiraled and I have ended up in my closet with some Kleenex. It's a bad idea. So I know that knowledge is power, and that's what I want to give you today. You may find yourself in the NICU and you may have just been diagnosed with ROP, your baby, ROP, which is retinopathy of prematurity, has to do with their eyes. Or you have a pediatric ophthalmologist that's all of a sudden starting to round and is now checking out your baby. So we're going to dive into what is ROP, but also what are some of the other common eye conditions that, or things that you should look for if you have a preemie. And sometimes they manifest themselves while you're in the NICU, and then sometimes it's something that you learn after you've been discharged. So I found an amazing pediatric ophthalmologist. Y'all are going to love her. So she has an amazing social media presence. She also has a really fantastic podcast called It's Good to See You, and she covers a ton of great topics on there. But our conversation is really educational, really helpful. I learned a lot of things, and I know that you will too. My guest today is Dr. Rupa Wong. She's an Ivy League trained, board certified pediatric ophthalmologist and the managing partner of Honolulu Eye Clinic. She's a dedicated clinician and educator, and she serves as a clinical associate professor at the University of Hawaii School of Medicine. She's also deeply involved in mentorship and advocacy, and she serves on the board of the Foundation Advisory Board for AAPOS and the boards of Make-A-Wish Hawaii, as well as Big Brothers, Big Sisters of Hawaii. She's featured by Parents, NPR, Newsweek, Business Insider, CNN, and People, and now Hand to Hold. And she also shares expert insights on both adult and pediatric eye health across so many social media platforms. You can find her everywhere at Dr. Rupa Wong. But let's get to this amazing conversation. Well, I'm excited to have the eye doctor in the room because now I'm all self-conscious. If you're on YouTube, I've got my glasses on. I hope they pass the test. But Dr. Wong, thanks for being here.
Thank you so much for having me. I really appreciate it.
Yeah, you have a great social media presence, but I love that you make eye health and all the things that we worry about with eyes relatable, because it's our window to the world. Like, it's how we see. And I know that lots of NICU parents have babies that have eye issues. So we're going to dive into that in a little bit. But I think it's always good to give people sort of a little bit of background. So why pediatrics and why pediatric ophthalmology? Why did you go down that career path? What led you there?
So the interesting thing about pediatric surgical subspecialties is that we do our training first in the surgery. So I did my board certification. I did my residency in ophthalmology, which covers both adults and pediatrics. And then I decided to do extra training in pediatric ophthalmology. And I kind of just always knew that I wanted to work with kids and babies. I mean, I babysat when I was 13. I love children. And so I went into medical school knowing that whatever I did, I wanted it to be a pediatric subspecialty. And I really loved the way, compared to some of the other pediatric fields, that you can truly intervene in a child or baby's life because their visual system is still forming. And we can truly make a very direct impact by doing sometimes extremely simple things like just getting glasses or wearing a patch. And so I finished my medical school knowing I wanted to go into pediatric ophthalmology, which is a little bit unusual. Most people just want to match into ophthalmology and then they decide if they want to do cornea or glaucoma or retina. There are all these extra levels of training and specializations in ophthalmology, but I had my heart set on pediatric ophthalmology and that's where it took me.
I like how you geek out a little bit on. I find that every time I interview someone that has a specialty in a certain organ, they're like super passionate about that particular organ. And I love it so much. So thank you for nerding out a little bit. So a lot of parents find themselves in the neonatal intensive care unit. Sometimes it's planned, sometimes it's not planned. And then they start worrying like, what are the things that could go wrong? And I know that sometimes whether you're a micropreemie parent, so baby's born at 24 weeks or later on, so give people an idea of some of the things that may occur with eye. I know you're talking about intervention and eye development. So kind of give us an idea of like what some of those things may be that parents may be seeing with their babies in the NICU.
So, I mean, first, my heart goes out for any parent that's had a child in the NICU. It's traumatizing and there's so much coming at you and there's so many specialists coming in. So as a pediatric ophthalmologist, I would round once a week in the NICU examining the premature baby's eyes for something called retinopathy of prematurity. So that's kind of the main thing that you're concerned about if you have a baby in the NICU, but it's not for every baby in the NICU. So it's really very specific. It's for any baby born less than 31 weeks of age. So if you are 30 weeks and 6/7, then you're seeing me. And or less than 1,500 grams, which is about 3 pounds, 5 ounces. So for any of those babies, and they did just a bunch of studies, and they found babies that were younger than that gestational age or smaller than that birth weight had a higher risk of something called retinopathy of prematurity. So they are they're put on our screening schedule, and you'll be seen either by a pediatric ophthalmologist or a retina specialist. In our rotation, we had 3 pediatric ophthalmologists and 1 retina specialist that would go around, all trained the same in this regard. And what we're looking for is abnormal blood vessel growth. And the whole reason for that is a baby's retina, which is the camera film of the eye. And I know a lot of people younger than us don't know what a camera is. They don't know what a camera film is. What I'm
They're
talking
like, what?
about.
Is it not on my cell phone? Yeah, we can
exactly.
Thank you for seeing me. Yeah, thank you for seeing me.
But I'm hoping most of your parents understand what the camera film is of the eye. And so it's got all the sensitive neural tissue. And those blood vessels that are in the retina, they don't actually develop until your baby is turned 38 to 40 weeks gestational age. So if you have a premature baby, they just haven't developed. So we have to watch them a minimum of every 2 weeks until those blood vessels grow all the way out, until we call them mature. Up until then, we're kind of just analyzing, is it immature retinal vascularization, which zone it is? So there's 3 different zones. Zone 1 is the smallest, zone 2 is a little bit bigger, and then zone 3 is like all the way at the out, right before the mature. Once they reach mature, then the retinas are just like a term baby, and so we're not worried anymore. But during that process, abnormal blood vessels can grow, and that's just because of all the things that happen in the NICU. They found that a lot of oxygen can also cause this, and just the birth weight and the gestational age can cause it as well. And if that happens and we don't monitor and treat immediately, that can lead to a retinal detachment, which can cause loss of vision. Again, that's actually really rare right now. So I want to emphasize, right now, I do my rotations at 100-bed NICU. So it's a pretty large NICU. It's the largest children's hospital in the state. And of those, I mean, when I'm doing a rotation for about 8 weeks, sometimes I go the whole 8 weeks not having to do any treatments for retinopathy of prematurity. So that just tells you how on top of it the doctors and the nurses are, because as more and more information has come out, okay, we should avoid extra oxygen. Sometimes the baby's O2 would desat, and then, the nurses in the old days would just blip, 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 get that oxygen up, right? Then they did the studies. That's not good for the baby, for their eyes. So let's just titrate it and not get super nervous. So all of that education has been really helpful. So we don't see it as much, which is fantastic.
It is good. Well, I'm glad that you mentioned birth weight because so our son was born at 36.3, so 36 weeks, 3 days, but he was right around 3 pounds and change. So he got put on the circuit. And I remember thinking, why is he here? Because he's older, but I hadn't thought about birth weight. That makes total sense. Okay, so let's dive into ROP a little bit. So retinopathy of prematurity, sometimes abbreviated as ROP. So if you see, Dr. Wong, a baby who has signs or symptoms of, we think that ROP may be a factor here. What are some of the things that parents might see? Like, I know you talked about some interventions and screening. So give people an idea of what that really means.
So, I mean, this is the hard part because parents aren't really going to see anything based on the baby's outward appearance. It's only through our exams. So what can you expect when the ophthalmologist comes by? Because oftentimes we're doing those screenings early in the morning. They typically hold feeds if your baby's getting fed because it can be a little distressing. So let's just talk through what happens because you might not actually be by the bedside. You might not witness it. Or there are a lot of parents that don't want to see it. I personally, when I was pregnant with my first of 3 kids, I stopped doing rotations during that time because it just was too hard for me to be examining these babies just emotionally and mentally, knowing that I had a baby of the same age in my belly. So a lot of parents don't want to see this. But what happens is the nurses typically are going to dilate the eyes. So that means put eye drops in the baby's eyes to make the pupils big. And that allows us to examine the retina. So it's just like opening a window a little bit bigger so you can see inside. And then what we use is an indirect ophthalmoscope. So it's a big headset with a light and some prisms in it. So we can focus the light. We use a lens. And then we actually use a speculum. So it's a baby speculum made for premature babies, and it keeps the eyelids open. So that can be distressing to see as a parent. And then we'll use one of 2 things. One's called a scleral depressor, or sometimes we'll use a very skinny Q-tip. But oftentimes what parents see is the wire that goes to the Calgary swab. So they see like they're putting a stick in my baby's eyes, and we have to do that to push the eye around. When you're getting examined, think about if you've had your eye exam as an adult, your ophthalmologist will say, look up and to the right, look to the right side. And we're examining the periphery of the retina by having you glance in all of those directions. Obviously, we cannot tell a baby to do that. So we actually have to forcibly move the eye. It doesn't hurt the baby. We use numbing drops for it. You know, the baby's super safe. It doesn't damage the baby's eyes to have such a strong light in the eye focus like that. But those are all concerns. And when I am then examining, it gives me the chance to examine the periphery of the retina. And that's where I can see what zone of maturation the retinal vasculature, the blood vessels of the retina are. So we know how concerned to be about the retinopathy of prematurity.
So would a parent, thank you for saying all that, because I think everything feels traumatic in the NICU, but whenever you can sort of gather information and be like, why are they doing that? That's super helpful. So would a parent, Dr. Wong, have a baby that might graduate from the NICU and then later on people may say, oh, the ophthalmologist may come around and say, actually, we think your baby may be at risk for ROP? Or is that something that you might know when you're in the NICU? I know sometimes as NICU parents, we sometimes fear like what other diagnosis is going to come about?
What other shoe's going to drop? The good thing is, typically, the retinopathy of prematurity is initially diagnosed in the NICU because you're not going to be discharged if they're preemie because of weeks of gestational age. You're usually not going to discharge a baby earlier than 32 weeks of age. I mean, usually they're going to stay in the NICU until that time. Or if they're very small, like your child was, they're going to keep them for a little bit and at least do the initial screening exam. Oftentimes, they might even keep the baby for that reason, just to make sure at least they get one screening exam in. You can have one conversation. A lot of hospitals now have a retinopathy of prematurity coordinator. My hospital does. It's a nurse who used to work in the NICU, a NICU nurse. And her whole job is to not only go to every bed with me and help hold the baby, but also to talk with the parents to explain what is retinopathy of prematurity, what should you be concerned about, what does the follow-up look like once the baby is discharged. So you have to see the ophthalmologist every 2 weeks minimum usually, or sometimes it can be every week. If I'm seeing some concerning blood vessels, I might want to monitor a little more frequently until the ophthalmologist says the vessels are mature. We're done. We don't need to worry about retinopathy prematurity. So those follow-up exams can happen as an outpatient, but your social worker, everybody's going to make sure that you've got that list of appointments so that you know that you need to keep coming back. But it'd be pretty rare to get diagnosed with retinopathy prematurity once you're discharged from the hospital if that wasn't something that was brought up. But if your baby was less than 31 weeks of age, less than 1,500 grams, 3 pounds, 5 ounces, you should have seen an ophthalmologist, or an ophthalmologist saw your baby, even if you weren't present in the room. So you can always ask the attending neonatologist, did an ophthalmologist come by, or what time or day are they coming, if you want to be in the room, just to at least talk with the doctor real quickly, because I would always reassure parents, sometimes they're pumping in the room, the moms are there, the dads, okay, everything looks good today. Don't worry, I'll see you in 2 weeks. So, and then the nurse will come back with all the detail of information, really explain what we're concerned about, but you don't have to worry that it's going to be something new that comes out you. It shouldn't be.
Okay. All right. So let's say you've been discharged from NICU, ROP's off the table, but you're concerned about something going on with your baby's eyes, because like you said, they can't always tell you, oh, mom, I can see this far, or I can't see this far. And traditionally we had 4 other children before we had our NICU baby. So I sort of had a general sense of like, when can they focus on an object? When can they see things? So give parents an idea of maybe some things that they should be on the lookout, or normal things that babies should be doing with their eye development, and when you should say, oh, perhaps we need to go see the ophthalmologist.
And that is such a great question, because of course, you all know as NICU parents that then the maturation's a little bit delayed.
Everything's
the development's
delayed.
a little bit delayed. So just Googling online, oh, the baby's eyes shouldn't be crossing at age 3 months. That's not going to hold for your child. So what we do is, once we even discharge the baby, once I'm not even worried about retinopathy prematurity, I tell the parents, I still need to see you in my office in 6 months. So that's going to be typically babies are discharged around term, right? So that's going to be at an adjusted age of 6 months, even though that's not their post-gestational age. By that time, they should be tracking, following objects. The eyes should be straight. There's a higher incidence of strabismus, misalignment of the eyes in preemie babies. There's a higher incidence of even needing glasses, of extreme nearsightedness, especially if they had to have a laser or some kind of treatment for retinopathy premature. Even if they didn't, there's a higher incidence of glasses. And yes, you can give glasses to a 6-month-old baby, which might seem crazy, but they look so adorable.
They do look adorable, yes.
And it's life-changing for sure. So those are things really as the baby is progressing, as you've got your child at home, you can just pay attention to the tracking. But I wouldn't be overly concerned trying to Google the developmental milestones, because you've got to just remember it's adjusted age up until at least age 1 for us in the eye field. So if the adjusted age is like 4 to 6 months and you're not seeing your baby track, absolutely, please call us, let us know. We're going to be concerned. If you see the eyes crossing in and your baby is 6 weeks adjusted, which might be a post-gestational age of 9 months, right? So, 6 months, adjusted, post-gestational 9 months. Some babies are 3 months preemie. Then we need to talk. But hopefully you've got that follow-up appointment so that you can address all of these. I haven't had anybody who's had to come in earlier than that 6-month appointment with any issues. And again, it's just about being careful and everyone knowing what to look out for. So I would look at the tracking behavior, the fixation behavior, and any eye crossing or eye wandering.
So I know that some people may have seen the babies with the glasses. They are super cute. We somehow managed to miss that milestone with a pediatric ophthalmologist. But if you see babies with glasses on, like, what are some of the things that those glasses might be treating, so that people have an idea of what that really means?
So there's basically 3 different types of refractive errors. Okay, actually 4, because we talked about your reading glasses, and this goes for children and adults. But in children, they can be nearsighted or myopic, which we do tend to see in preemie babies. They can have astigmatism. Astigmatism just means the shape of the front surface of the eye. So the cornea, which is the clear dome-shaped covering of the eye, is a little bit more oblong. So instead of like you cut the top of a basketball off, it's more like you cut the top of an egg or football off. Nothing dangerous. It doesn't mean anything, but what it does is it's a type of lens we need to put in to make things more clear. Otherwise, things look a little more stretched out for the child or the adult. And then there's also farsightedness or hyperopia. Actually, all babies are hyperopic. So this one is not something that we typically need to give glasses for unless the eyeballs are very, very small and they're very, very hyperopic. But usually it's more than nearsightedness and astigmatism in the preemie babies. And then the fourth one is what you and I have, being over 40, which is presbyopia, needing reading glasses. Obviously, it does not affect babies.
Yeah, I know. There's so many things that I wish I was like, could we have prevented this? And my eye doctor was like, yeah, that's not the way that works, Kathryn.
No.
You're just getting older. So, okay. So if a baby has to have either surgery or intervention, give parents an idea of what that might look like.
So when I trained, 20 years ago, the standard treatment for retinopathy of prematurity, because these blood vessels are growing out and they're growing out because of the extra kind of oxygen is thought to make these abnormal blood vessels grow. And they're not good blood vessels. So they break easily and they bleed. And that's what causes retinal detachments. We used to put laser, and the laser treatment depends on the hospital that you're at, where I trained at and where I used to work at Boston Children's. We would just do it at the bedside, meaning there would be an anesthesiologist that come in, help give something to the baby so that the baby would sleep. And we would just do the laser right there in the crib or put them in a little bassinet to be able to do it. At the hospital I work at now, they just want to be able to control putting a baby to sleep because that carries with it risks. So we do it in the operating room. And that's just where the laser machine is, and it's just considered safer at our hospital to do it that way. Neither one is wrong. It just depends on your hospital. And the laser just looks almost like the same headset that I wear when I'm examining the baby. But for me, it's a lot heavier. And then I use a foot pedal and you'll hear this little ding, ding, ding. And typically we're putting in about 2,000 shots of laser in each eye, which seems crazy. So depending on how much retina needs to be treated, that could really depend on then cause how many laser shots that we're doing, and can take anywhere from about an hour to 2. Sometimes some people are real fast laser people, and so they'll do it even at a shorter time. But now we actually also have a treatment that's an injection that they inject right into the baby's eye, right at the bedside. Takes, 5 minutes max, as opposed to the baby needing to be put to sleep for an hour. So this is usually the treatment that most people now go with, and it's an anti-VEGF. So VEGF is vascular endothelial growth factor, because we're trying to stop the abnormal blood vessels from growing. And they found they can use this medication, which they also use in macular degeneration for adults, for older adults. So it's the same medication that they inject just into the eye and is safe for most babies, for all babies, but again, still need to be monitored. Even if the babies had treatment, laser or the injection of the Avastin, which is the generic version of it, they still have to be checked every week, usually after treatment, just to make sure it doesn't worsen, that we don't get a retinal detachment. It has to get to a very certain stage of retinopathy prematurity before we do the treatment. We don't treat every single baby that has retinopathy prematurity. Sometimes they have it, but it's mild, so we can just observe it. And a lot of times that's going to clear up on their own. And when they looked at the studies, they said, all right, it's got to be this particular type of retinopathy prematurity. So I'm looking every time I examine for those features that would qualify for treatment. And it actually, in my hospital, if I think a baby needs treatment, I always will get a second opinion from another pediatric ophthalmologist. I've served as a second opinion for others because we just want to be in concordance. We want to make sure we're doing what's right. And there's a lot of subjectivity still with it, because it's like, all right, does that blood vessel look tortuous enough to call it, stage 3? So we'll always just bring somebody else in and then decide on a treatment plan. But that's kind of what to expect, laser or an injection.
This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Be sure to download our app in the Apple Store or on Google Play, or you can visit our website to discover all the ways that we can support you as a NICU parent at handtohold.org. You can join one of our support groups, sign up for counseling, find loss and bereavement support, request a peer mentor, or check out our educational resources and family stories. And all of that is at no cost to you. I'm really glad that you said that ROP isn't always something that you necessarily intervene with that, because I know as a parent, you're thinking about how many surgeries or how many procedures is my child going to have, and you hear a certain diagnosis and you think, oh, there's only one treatment plan. So if my child has this and this happens, so it's reassuring, I think, probably for a parent to hear that it may just need to be watched and monitored, and then you'll see what happens. But our babies are tough, and sometimes they surprise you. Sometimes they do funny things with the monitors, but then sometimes you look up and you're like, how did we dodge that? Like, how did we get past that? So I'm glad to know that that's a possibility.
I've seen so much just as the person caring from the other side, that babies that quite honestly, they pulled off life support, right? They pulled because they thought, all right, there's too much wrong. But then survived and thrived. And I mean, it's amazing. So the good thing, yes, I definitely want to reiterate for parents, if you're in the room and the ophthalmologist says, okay, I'm worried there is some retinopathy prematurity, that is not cause for alarm. Your head doesn't have to, because mine would go there with my three kids. Okay, now we got to do surgery. Now we got to do this. Now we got to do that. That is not necessarily the case. The majority of the time, it's something, it just means we might need to do a little closer observation. And a lot of the time it improves on its own. So that's really, I want just to reassure parents just like a little bit. I mean, yes, there's a possibility of needing treatment, but like I said, usually, and when I'm doing my rotations and I'm going every week, I'm not treating. I'm seeing like 20 babies a week. Those at the end of 8 weeks, sometimes I finish the rotation. I haven't had to do a single treatment. So, but there are a lot of babies with retinopathy premature that I'm following. So hopefully that gives a little bit of comfort.
No, I'm a big fan of a boring specialist visit. The more boring, the better. So I'm glad.
Exactly.
If you don't have to do much and I don't have to do much, all is good. So some people may be wondering, because we hear there are so many specialists that sometimes roll through a NICU. So difference between an ophthalmologist and an optometrist.
So ophthalmologists are physicians that go to medical school. So, 4 years of college, 4 years of medical school. That might be an MD degree like I have, or it can be a DO degree. This is where things get confusing. Then we all do 4 years of residency surgical training in ophthalmology. And then anybody could do a fellowship training if they want. 1 year in pediatric ophthalmology, 2 years in surgical retina, 1 year in cornea if you're going to a LASIK surgeon. An optometrist does their 4 years of college and then goes to 4 years of optometry school, which only focuses on the eyes. So they're not a medical doctor. You might sometimes ask me, okay, tell me about my GERD, or I've got this issue and I studied that in medical school and I still read the literature so I can answer. I know how medications work within the body. For optometrists, they're focused only on the eyes and whatever's in the eyes. So they don't get the same pharmacy, surgical. There's no surgical residency. There's no residency after optometry school. So that's it. Well, that's not exactly true. Now there are residencies, 1 year residencies, but they're not surgical in nature. So you can do a 1 year residency after optometry in pediatrics or something like that. But they basically finish their optometry school and they can practice. We are mandated to do a minimum of 4 years in addition of clinic, medical, and surgical training. So that's kind of the difference between them. So a lot of optometrists will do your glasses or your contact lenses, or they may be following you for glaucoma. There are pediatric optometrists as well who might follow older children for their glasses or even a little bit of eye crossing, but typically they absolutely will not see premature babies. They don't go on they don't round, they don't treat. They should not really be seeing you in follow-up until everything is stable. At least I would not transfer to my optometrist. We have a great pediatric optometrist in my clinic that I personally trained. I wouldn't transfer care to her until the baby's at least 3 years old, because I really want to make sure that nothing requires surgical intervention or a medical intervention in the form of an injection or anything before going to an optometrist.
I think sometimes we worry.
Of course.
Is this something like how long do I need to worry about this before we need to intervene? Or can I put this in the don't need to worry about this category? And then, we focus on other things. So I think parents are always sort of weighing how much do I invest my worry and anxiety in this particular thing? And how many things can I just let go? So
I mean, it's so hard because you're hyper acutely aware about anything that's going on with your child. And it's I really recommend just always, of course, parents, as a parent myself, like sometimes I have to be my child's advocate, right? You're with your kid all the time. You know what's going on. So it's reassuring then to know, like, okay, most of the time, this is nothing. We don't need to go see a neuro-ophthalmologist or get an MRI of the brain, which they need to be sedated. But I totally understand if you ever have a concern too, hopefully you have a relationship with your ophthalmologist that you can call them up and ask them, and they'll squeeze you in and just talk to you face to face to reassure you.
I just have a couple last questions for you. So, if you're finding yourself in the ophthalmologist office, maybe you somehow missed that specialist when you were in the NICU, walk us through like what is a normal eye exam for a child and maybe some of the key things that you might be looking for as their eye develops and as they get older.
So it just depends on the age of the child. Even babies, like 12 months old, we can check their vision. We do it with these cards with stripes on them because it's been shown that any vision, any eye is going to gravitate towards a side with stripes versus something that's less visually interesting. So we can actually get kind of a rough idea. You don't have to read the eye chart. If they're 2 and above, we might do a matching game because vision is really important. That's our vital sign. That's like going to your doctor and getting your blood pressure checked or getting weight on the scale. That tells us about the health of the visual system of the eyes. We will do sometimes a matching game with different shapes, even if the kid is not verbal yet, and they can point to I'll show them a square, and then they can point on a little card. Which one is the square? Which one is the circle? So we can even check their vision. Then usually the ophthalmologist is assessing the motility, meaning making sure that the eyes are straight, that they move in all the different directions. We want to just ensure that there's no cross eyes or wandering eyes. And then we'll take a look at the front structures of the eyes, the eyelids, the eyelashes. There are all sorts of different little masses that can grow that are totally benign. Don't need to worry about them, but they can look a little funny. They can be concerning for parents. And then we're going to put the dilating drops in. And the dilating drops for kids and babies is actually stronger than the dilating drop for adults. And the reason for that is their eye muscles are stronger. So it takes a lot more to open up that pupil than it does for you and me. So because of that, the time to dilate takes longer. It can be anywhere from 30 to 60 minutes sometimes. Now, part of that is because the babies cry, the eye drops out, but part of that is just because their muscles are stronger. And so you might have to just schedule for a long period of time is what I'm trying to. If you have a kid or a baby that you're coming in to see the ophthalmologist, sometimes those appointments can take 1 to 2 hours. It is not the same thing as going in as an adult. Think about it. You can just read that vision chart and boom, boom, boom. Your dilation takes 15, 20 minutes. You're done. But the whole process takes a lot longer for pediatric ophthalmologists. Also why, it's more of a procedure, more of just an investment for your time. And then we'll do the same thing that we do with in the NICU or with an adult patient. Examine the retina. We're looking at the optic nerve. We're looking at the retina, making sure that functionally everything is there for the child to see properly. So, and then we're going to check the refraction, which sounds crazy. Refraction means glasses prescription. So on every kid, I am using a tool and I use all different lenses. And based on the light reflection back at me, I can tell if your kid needs glasses, even without them telling me something is blurry. So that's how we determine if a child needs glasses. This is the best way to do it. It should be done after dilation. Even all the way up until age 10, I recommend the prescription only be given after dilation because otherwise it's very possible to give too strong of a glasses prescription or an incorrect prescription. I know there are a lot of shops around that'll give, come on in, $89 to get your kids glasses. If they don't put the dilating drops in your eyes, that's a red flag. That's not a comprehensive exam. And sometimes they won't because it takes a long time. Can't see as many patients as quickly, but you got to do it right. So it's basically what to expect from the beginning to the end. Usually if it's a pediatric ophthalmologist, I have a separate peds waiting room. They can play around. I have technicians who are really trained in just easing the discomfort and the fear and the anxiety for a child. Sometimes you're in places though that don't have a pediatric ophthalmologist because 90% of the counties in the United States don't have one. We're kind of a dying breed. So I know that sometimes people are seeing adult ophthalmologists. It might not be as easy of a transition, but they're doing everything that they should be, hopefully. But if you can get into a pediatric ophthalmologist, that's always going to be a little bit better.
That's funny that you say how much longer it takes because we had to take one of our kids in recently. And I was like, why is it taking so long for the drops to work when I know how fast they work? And I just kept thinking, so then I start freaking out like, is is this a sign that things are more complicated or things are even more serious? And to know if I had only known that her eye muscles were stronger,
Yeah.
then that could have saved me some concern and worry. Thank you for that.
And also the dilation lasts longer because we use stronger
Yes.
dilating drops. So it lasts longer to reassure parents when you look at your child and maybe their pupils might be dilated the next day. That's normal. I mean, it should usually wear off within about 6 to 8 hours, but for adults, it's like 2 to 4 hours, then it wears off. So if your child's complaining, if they're verbal, they can't see up close, that's normal. Give it sometimes a full 24 hours before you get worried about that.
Yeah. No, that's fascinating. All right. So I want to ask you one last question. I always love asking people for advice because you have specialization in that. So if a parent has just had their child diagnosed with ROP, what would be your best advice to them as they receive that news?
I think just to stay calm. I know that's so hard, but like I said, most of the time, it's not going to be something that requires treatment or surgery or intervention. Stay calm and keep those follow-up appointments. That's really, I mean, you would be surprised at the number of times people miss appointments with me. And it's a really critical stage. So delaying an appointment 1 week can be the difference between me catching something early versus not. So stay calm, but maintain those appointments.
That's really good advice. Dr. Wong, thank you for being such a great advocate. I know that you have your own podcast, so we'll make sure that we link to that in the show notes. You had some great ones. What was the one that I just saw? It was how to spot hidden eye conditions with kids. And I was like, oh, I'm going to have to listen to that. So there's some great episodes in there. So thank you for all that you do for our kids and for eye health. Well, I'm going to start off today's 2-minute take with a little bit of a story. When I was in 4th grade, I had an amazing teacher. Her name was Miss Coyle. That's Coyle. You might say that differently. Miss Coyle always told us in order for it to be a successful day as students, we had to learn 3 new things every day. And even as I got older, I would find myself thinking, oh, I've only learned 2 things today. And I would bust out a book or an encyclopedia back when we had those in our houses and say, like, what new thing can I learn today? I hope that in this podcast that you checked off all 3 things. There were many things that Dr. Wong shared that I learned about the eyes, particularly about ROP. So maybe your baby has recently been diagnosed, or maybe they are screening for ROP. And as you listen to this episode, I hope that it gave you a lot of solace to know all the strides that they are making in treating eyes, particularly in preemies and neonates, and the prognosis and what that can look like for a baby. I always find comfort in knowledge. Sometimes I think, I'll say this, when we were first put into the NICU, I was terrified to learn things because I was worried that it was going to send me spiraling, and some days it did. But I also found that on the days that I could take a deep breath and be like, okay, today we're just going to focus on the kidneys, or today we're just going to focus on the heart, or in today's case, we're just going to focus on the eyes. If I could isolate that and say, okay, deep breath, what do we know and what can we do? And so today's episode, I hope, gave you the deep breath to say, what do we know? And what can we do? Pediatric ophthalmologists are doing amazing things with an ROP diagnosis. And I hope today's episode gave you, if that's you, gave you a big old deep exhale to say, okay, I learned my 3 things, and now we're going to go do the next thing. So Dr. Wong, thank you for being on the podcast. We have lots more episodes coming. Thank you for giving us a rating on podcasts, whatever platform you listen to. And if you're a YouTube person and you love videos, thanks for watching us over there. We will see y'all next time, but this is a little bit about what you're going to hear the next time you hear the podcast. You've got your head in the crib, inches away from them. Are they breathing? What's happening? Yes.
Their chest rise?
I did that so many times. Yes.
And even as a pediatrician, like, I was waking up. It's been 15 minutes. I didn't hear anything.
Exactly.
Okay. Yeah. I so much anxiety. And even, as a NICU parent, as, a normal parent, as a ER doctor mom, like, we're all going through a lot of the same stuff because we're all just like, what's going on with my kid? Are they okay?